back, I humbly request if you could move in front just to make it easier. We will have, the session is running for about 2 hours, 30 minutes. So we'll start off with the first hour of an open panel discussion with our lovely panelists, who will just introduce us to the concept of healthcare financing in relation to our theme on SDGs, and also give us a short introduction of what they do and how their organizations are impacting healthcare financing. Then we'll have a 30-minute networking break, and then finally we'll conclude with just each of the panelists giving us their views on healthcare financing and a question and answer session from you, our lovely audience. Do remember to follow on Twitter at WHSS 2017, and you can also post your questions there, and we will, if we have time, we will check them out and ask them to our panelists. So thank you so much and welcome. So starting with my first panelist, her name is Renee de Jong. She is a global health advocate at WHSS based in Amsterdam, the Netherlands. And she focuses on sustainable financing for our health and strengthening health systems in Africa, as well as health systems advocacy partnership. Renee, please could you say hello to our lovely audience and probably tell us more on what you do concerning healthcare financing. Yes.
All right. Yes, does it work? Great. So I'm Renee de Jong, and I work at WHSS in Amsterdam. And we're global health advocates, which basically means that we're a civil society organization. And our starting point is that health is a human right. So everybody should have access to it, no matter where you're from, which means you have, who you are, everybody should have access. Now, we also believe that the governments are responsible to protect people's health and make sure that people have access to healthcare. Now, what we do as global health advocates is mainly lobby work. So we collaborate a lot with other organizations, and for example with universities to get latest science, and we try to talk to politicians, to policymakers, to stress the urge of what is needed for healthcare, how healthcare could be improved. And we look at different topics, for example, human resources on health, also on medicines, on chemicals, and on healthcare financing. And we try to move policy forward so it's better protecting health eventually.
Thank you so much. Our second panelist is Dr. Claude Sekabaraga. He is a medical doctor as well as a senior public health and healthcare financing specialist with over 15 years of experience as a hospital director, head of quality healthcare division, as well as director of health services. He is also one of the founders of $1 Health Insurance Limited, as well as a managing director of Quality and Equity Healthcare Limited and International Doctor Booking. Welcome, Daktari, and please could you tell us something small on, or more on what you do?
Thank you. It is really a pleasure to be together and discuss the health financing, as I was involved in health financing since maybe 20 years. I was Director of Policy and Planning in the Ministry of Health, and I was with the World Bank for 4 years. Currently, my organization is Quality and Equity Healthcare. I'm providing support to especially government and private organizations for public-private partnership and a universal health insurance scheme design and support. I have some programs and some consultancies in health financing policy and planning. Then this is what I'm doing now. The big part of my work is consultancy services. And some project I provide some management because those organizations are not represented in Rwanda. I'm more focusing on how private sector can be involved and play a bigger role in health financing, what is not the case now, and what we should see how we can really provide some support and improvement. Thank you so much.
Thank you so much, Dr. Claude. And finally, our last panelist is pharmacist Danny Mtembe, who has over 14 years experience in the pharmaceutical field. He is the CEO of MD Conceal Medical Supply, as well as the managing partner of Pharmacy Conceal, which was established in 1983. He is also a teacher at the National University of Rwanda. And for the few Kenyans in the house like myself, you might have encountered him as your external examiner at Mount Kenya University. And I'll welcome him to just say a little bit more on what he does. Especially, we've learned today is more of multidisciplinary approach and how we can work together as a pharmacist, as a doctor, as a global health advocate. So welcome so much.
Thank you very much, Marie-Claire. Yeah, I am a second-generation pharmacist. For some who don't know what it means, it's basically that I found an organization. When you hear about 1983, I obviously didn't start it, but I joined an organization that started back in the Congo Democratic Republic in Kinshasa. And I actually got more involved in the private sector. I actually represent the Association of Retail Pharmacists, which includes about 300 retail pharmacies. And that association now is part of the Rwanda Healthcare Federation, which is in part of the East African Healthcare Federation. So basically what we do is a lot of advocacy, but we're also trying to promote the sector, trying to move away for only trade-based kind of activities, but also thinking out of the box, especially like Rwandans or East Africans or Africans, getting more and more involved into manufacturing. So the reason why I also get involved into the teaching field is because I like the interaction or the different interactions with students, whereby I learn new technologies, things that I may not have come across during my student age, but also I give them my experience as an entrepreneur, so that it could be a kick for anybody, just like as myself, because I was well mentored in my early age, and that was really helpful. And I feel like giving back to the younger generation is what it's all about. Thank you.
Thank you so much. And last but not least, please give yourselves a round of applause for coming here this afternoon. I know you are spoiled for choice, but you've chose this session, and we're really grateful to have you here. So first, I'd like to ask all our panelists, with your vast experience, why is healthcare financing such a crucial tool in our health systems, and why should we as World Healthcare students be involved in it? I'll start with Renee. Yes.
Okay, thank you for this question. I think the reason why health financing is so crucial is because nothing is for free. I mean, healthcare is extremely important for everyone, but it's not going to happen if a doctor doesn't get paid. If you want to get medicines, I mean, it needs to be produced. There needs to be finances to do that. So the discussion then becomes, how can we get those finances or the money to pay for the services which are needed? And I think a lot of countries have been struggling in the past to get the money. I come from a country where I'm from the Netherlands, and we have the funding which is needed for healthcare, but it's been a long way for us too to get there. It's been political choices why we now have the healthcare that we need. So if we look at what healthcare students can do, I think it's important. I'm very happy you're all here. It's very important that you understand how resources can be raised, because I mean, right now maybe you're a medical doctor, but who knows where you're going to be in 10 years, if you're going to be a leader or a politician. And if you know what you can do for healthcare, how finances can be raised, how it can be equitable, distributed throughout the system, I think that's very much needed.
Thank you so much. It's okay.
Okay. Thank you. I think let us recognize the fact that current healthcare system, how delivery of healthcare is based on its industry. You can't, as in the past time, say in traditional medicine, I can go in the bush, get some herbs, get treatment. It doesn't work now. Then from the people, the students, training is expensive. Paying staff is expensive. This is why in many developing countries, they invest in training, then they lose investment because the one they train went to deliver service where they can get good payment. Then let us be realistic. Healthcare is money. You have no money, you have no healthcare. For me, it is clear. I don't know, we debate about it, but for me, it is the pillar of the health system. If I have money now, I don't care. I take my flight, I go in the US, I get care. But if this is why I say we need locally financial resources, well-funded health system, then population and accessible financially, and people can get quality, because healthcare is life. It is human right. It means getting your right to life, it is human right. Then we need money for that. This for me. Then the current technology we are using, more and more technology. CT scan for diagnostic. When I was doctor in my district hospital, I didn't use the CT scan. Maybe I was using just my head, from my head, and a few technology, X-ray. Then more and more industry is bringing us highest technology, expensive technology. We need to raise more financing for that if we need to get those access to those technology, and because those technologies provide for us better diagnostic, better treatment, and our health professionals, they are investing their resources for education. They need return from investment. They want to be well paid. Let us really discuss it, because even you are a student in pharmacy, you need to understand that without financing, without money, you not deliver service properly. And I finish by that, because many times I interact with colleagues, biologists, other physicians. We say, okay, we need this technology. Maybe we need to use any CT scanner technology. I say, okay, now let us work on how to get financing for that. This is not my job. You want a technology, but you don't want to think about money to get this technology. This is what we need to change our mindset and see how we can bring financing part of a daily work. Thank you. Sorry for the...
Thank you very much. Now, about being last, when brilliant panelists have spoken, you tend to kind of copy what they have said earlier, which is going to make my job a lot simpler. I like the fact that she mentioned that there is no free lunch. I would add to that that there is no free lunch, and if there is free lunch, like today, if you had free lunch, there is somebody who paid for it. So, like Dr. Claude said, it's all about where money is raised, and healthcare is about money. So from an entrepreneur perspective, and I'm talking to some of you who are students here, there is no free lunch at all. Healthcare has a cost, and the cost is pretty high. On the pharmaceutical sector, it's really where you see that healthcare is extremely costly. It costs a lot of money to insurance companies. That's why you see they scout for the cheapest medication of quality. There is a lot of negotiations that are going on with pharmaceuticals, and pharmaceutical companies at the same time are trying to make money. So again, it's about money, and maybe they will come back again through a CSR activity, bringing back the money. Or they'll pay taxes to the government, and maybe governments will create funds. So like it was said by other panelists, it's about money. It's about how much money institutions, NGOs, private entities are able to raise. So if you come as a new player in healthcare financing, or you're seeking for finances, you are in the same pool. You are scouting for a lot of money. Lobbyists will scout for money from governments. Private companies will seek for tax exemptions, and insurance companies will work out deals with pharmaceuticals and service providers. That being said, there is a huge challenge for developing countries like ours. We want quality services, we want quality medication, and everything is costly. So you have alternatives. So you have less scrupulous service providers, manufacturers that will flood our markets with poor equipment, with poor medicines. You will have counterfeited products, you'll have substandard products, and you'll have very poor services. So I'm going to throw back the question to either the moderator or the audience. How it's probably like a chicken and egg kind of situation. Who pays what, and who runs after the other? Because the insurance companies need contributors. Pharmaceutical companies need people to buy the medicines, and they have to be affordable to be purchased. But at the same time, they have to be able to be refunded. So it's a kind of vicious cycle, and for our markets, I'm talking about the African markets, for instance. It's a big market. It's a growing market. We have to be able to see how to strike balances. We already have challenges to set regulatory frameworks. We have challenges to run tests. So sometimes we just collect and just receive and recycle what others have not been able to use, what has failed as systems from other companies. Thank you.
Thank you so much for that. I think one of the key challenges we face is that healthcare financing is not well embraced in our curriculum. It's something that's more emphasized as we pursue probably a master's in public health or want to know more of healthcare financing. So I think I want to pose the question to the audience. By a show of hands, how many of you have been comprehensively taught healthcare financing at an undergraduate level from our members in the audience? Or has any one of us have been taught at least introductory concepts to healthcare financing? Okay, at least we have a few more hands. Are any of you interested in healthcare financing? Let's start there. Okay, so at least there is hope. So we, as healthcare students, we are interested in healthcare financing, but it's not taught in schools. So I'll start with Pharmacist Mutembe. As a lecturer, as our teacher, why aren't you teaching us about healthcare financing? Because I think the best way to solve a problem is to know about it.
Thank you very much. I think in healthcare financing, my first big chapter, and it's probably going to be a disruptive talking, it's going to be entrepreneurship. How you build yourself, how you think of manufacturing instead of trading what others have manufactured, how you become a provider rather than on the receiving end. There is a big challenge, and I believe that earlier in this room it was mentioned. You ask people, or you bring solutions to people. You think you're bringing solutions to people. You bring healthcare to people, but sometimes the same people actually have basic needs that you haven't thought of. You'll bring medicines to prevent diseases, but they will need food, initially. So I think it's a process, and like it said, it's multidisciplinary. You have different actors, and of course, I wouldn't teach people to expect money. I would teach them to raise money, to think production, and that will be the initial step. And maybe I'll leave my colleagues to go for chapter 2 and chapter 3s.
Okay, thank you so much. Dr. Claude, as a healthcare financing specialist, where do you think we are going wrong? Clearly, we all have that interest of knowing healthcare financing, but it's not being tapped into. What can we do to improve on that so that we are able to be empowered, and as Pharmacist Mutembe has said, to be more of providers rather than just waiting for the finances to come through and just manage or use it accordingly? Thank you.
I don't know if really how to proceed for me, because when at the education sector, I want to design a program for training a doctor. I will say, okay, I want to train the doctor to do a technical work. I want this doctor be able, if he is or she is a surgeon, to do the best surgeon one. Then I focus on technical skills. Then what now we are facing, it is the new, the new way, the new technology used by doctors and nurses and other health professionals, because it becomes more and more expensive. Then some knowledge are needed. I think we should recognize the gap. Even it is not to say me, I'm doctor, I'll be investor to build hospital, maybe not, because maybe you can be employed by other people, other investors, but at least how you mix your technology and the resources, this is, I think for me it is necessary. Because if me, I'm just using different products I have without to care about the cost of those products, I think something's wrong. Something's wrong, and this is the case in many times, because people say, okay, me, I'm don't care, I can use expensive drug to treat when I can. Let us just give an example. If I can treat a simple malaria by the protocol costing maybe $10, then for me, because I don't care about the cost, I want you to be treated quickly. I give you a treatment, I prescribe a treatment for $50. Something's wrong.
for country, because I mean healthcare at the other way around also provides you with more gross domestic product. If you have healthy people, you'll have probably a healthier economy. So it goes both ways.
Thank you so much. So you've said it goes both ways: healthier people, healthier economy. Our healthcare providers are also very happy. But what can we do, or what as healthcare students, we have various organizations represented here, from medicine, pharmacy, dentistry, nurses. What can we do, Dr. Claude, so as to ensure probably we're in the right track, because we're the healthcare professionals of the future. We'll be the ones who will be faced with such tough decisions. Is there anything we can do now so as to prevent what will happen in the future, or do we have to just wait and see where this goes?
I think let us go in data and see the reality. The GDP, gross domestic product, that is the indicator of economy of a country. Let me take East African community country. I exclude Kenya. I put remaining countries. Average GDP, $600 per capita. Across the 3 or 4, the GDP, public tax to GDP, this is government money. What government can take from economy? 15%. It is around $70 per capita. You understand? $70 per capita, because this is what government is able to get from the economy. The economy, we need to be realistic, is in the hand of private organization and people. This is the reality. I will show you the data after. Then, estimation now for WHO for getting primary care, is it $80 per capita? It means even you multiply 15% of Abuja declared by 4 times, you not get good salary for staff. Let us be realistic. There's no money in the government pocket. There's little money in government pocket. This is why we need innovative way to get more money for private pockets. This is what I think there's somewhere people don't know the picture, the reality of financing. Government financing for developing countries. This is totally different. Why? Because the economy of those countries are telling you developing countries. Economy is essentially informal sector. It is not formalized, and government can access to those information and collect tax. What is not the case for developed countries, because economy is essentially formally organized. Government won't know what you get. Government can get tax, and because government has a huge responsibility in terms of some services like healthcare, because there are some public goods. You share risk. People also should know that when I'm sick, you are potentially sick. It is not just because I'm rich, you are poor. You are rich, but we are living in the same environment. You are sharing our area. This is what we need to know. Problem is the reality. What happened for those strike, for staff? For me, I will not blame anyone, because my family invested for me. I want to have at least a minimum of quality of life. And my family, everyone expects from having a minimum of quality of life. But the reality from government maybe we're not saying openly, but if you go in the budget of government, I was the director of planning in the ministry. There's no money, even you take all money in the Ministry of Finance, you give to healthcare, it will not be enough. It means 15%, nothing, peanuts. Then for me, and we have some example, we need to have some sharing of our responsibility. This is why, for example, in Rwanda, I am very happy to say, okay, me and government, I can provide what I can have, and the better, I will channel my resources to people who can't pay. Me, for example, if I can pay my treatment for malaria, why government should pay for me? This is waste of money, because the need is huge. Public resources should be focused on low-income people, because people who can pay should pay. If I can buy mosquito net, government has not paid for me. I need government should pay for people who can't pay it. This is first thing many governments don't do. Then, because they have no, WHO is developing a very good approach, strategic financing, strategic payment, strategic purchasing. Government has no to use money without to strategize, because money is little. This for me what country should do. Government should seek, review the financing aspect, say, I have this money, but the need is huge. Let us focus. I focus two areas. One, public good, prevention. I invest in prevention because it is cost effective. Second, I focus to people who can't pay. If you have no resources, as the government in Rwanda is paying for a first level and second level of low income for poor population, take your little money, focus for them, pay for them. Second, people who can pay, leave them to pay. It is complicated, but you should go. Some countries say, no, that's very complicated. I can't know who is rich or is poor. Then I pay for everyone. You have no money to pay for everyone.
So there's no money to pay for everyone. So if you can pay for yourself, pay. If you can't, government should come in and help you. Okay. You've mentioned about innovation, and Pharmacist Mutembe, you've won a prize on technology and innovation, and I wanted to ask, earlier this morning we had a huge debate on technology replacing the healthcare workers. Is technology applicable here in healthcare financing, and does it pose us at a risk of doing double trouble and replacing the people it's supposed to help? Thank you.
Thank you very much. First, I just wanted to compliment a little bit on what was said earlier. I think a healthy economy in a country is driven by the private sector. So a healthy private sector, drives the economy, and you can tell by an increase in GDP. We've seen it here in Rwanda with of course, the government set the carpet for private sector
engages in healthcare, that everyone has access. Remember the goals from sustainable development, from universal health coverage. Everybody should have access to good quality care. So there should be no one left behind. Yes. So then if you talk about insurances, we hear it coming up over and over again. And small insurances probably won't do it. It has to be big pools with more money, because more people, because you can share the risks. Not everybody will get the same diseases. But if you're more people in one group, and it's mandatory, because otherwise also maybe the people who are very poor, they might not insure themselves simply to save cost. Or people, the young people particularly, who are healthy, would not insure themselves because it's not that attractive. It costs a lot of money. But if we don't have this solidarity where the young pay for the elderly, or the people who are working maybe for those who are unlucky enough to have another job at the moment, we might not gain the resources we needed. And I think the same thing applies to global solidarity. I come from a country where we're very wealthy, and we should also share in that. So I'll go through it quickly because we have so little time, but I think taxes are very crucial. Because in the end, you have to find a way how you can get resources from a place where there's a lot of money to those who are not able to afford it or pay for the healthcare themselves. Because, as I said, it is a human right. Everyone should have access to it. So it's important to have progressive taxes, which means people who have more pay more. You can look at value-added tax. Be careful with food or with products people really need, like pharmaceuticals maybe, because that's not necessarily beneficial. But if you think about luxury products like fancy bag, perfumes, people could maybe pay more for those. There's also the sin taxes, so on unhealthy products. But we need to be, there's a new way, for example, to think about pollution. There are a lot of industries or actions we do which are bad for health, not as an individual maybe, but from industries if they pollute the air. And we could also think about taxing that. We have a big climate change issue, and we could think about taxing carbon emission. Because if you use that money for healthcare, it can also be beneficial for society. Next slide, please. So lastly, I would give you a little bit of a global perspective, because I think aid comes also in. There's some countries who are not able to make that $86 per capita, and it's important. I think that other countries can definitely provide help. However, we've seen in the past so often that it's been that help which has been giving a higher burden for the healthcare system, or that it's parallel efforts. Everyone's doing the same thing. We're multiplying each other, and it's not complementing each other. So I really hope that when we look at universal health coverage, it's a long-term goal. It basically can go on forever. But let's say you set a 20-year goal, and everyone who comes in with aid has to make sure that their plan fixes or matches with that 20-year plan, even if it's only for 5 or for 3 years. And I also advocate in the Netherlands that our government, whenever they provide aid, make sure that it is additional to the country, that it's helpful, that it's not giving an additional burden. Lastly, civil society. I mean, of course, I am civil society myself, but it's very important to listen to them. It's not a sector which has a lot of money, like maybe private sector or pharmaceutical sector. No, they're often representing people who don't have a lot of things. But it's so important to include them and to make sure that, to use that watchdog role, they can set things moving. They can make noise in society, get people together to come into action. So yeah, it's important to take them into account. Then I'll skip the summary to save time, and I did it very short. Next, please. One more? Yes. So I'd like to thank you very much. I feel very privileged that I could talk to you today about this topic. And if you're interested in our work as a civil society organization, you can always look us up online. We're on Twitter. We're always happy to hear about other perspectives, because we just pass on information. We talk to politicians, but the only way we can do it is when we know what's going on the ground. Thank you very much.
Thank you so much, Renee. So as with one key thing we need to pick up we need to also engage our civil societies in our quest for financing in healthcare, in our quest for universal health coverage. If we can engage our civil societies or even be part of them, or even with our respective organizations on a country level. Speaking as a Kenyan, I know there is Msake and there is KEPSA. Maybe you should engage your civil societies or maybe borrow a leaf from them on how you can be advocates for better healthcare financing as well as universal health coverage at your respective country levels. Next up, I'd like to invite Dr. Claude to give us his wisdom on healthcare financing. Welcome, Dr. Yes.
Thank you. Next, please. Next, please. I think I like the WHO framework in terms of health financing. You can get from WHO website, but it covers really all aspects. If you are a student, you want to understand different pillars, I think this is the best way to go. Next, please. Next. Then this gentleman in green, she's showing up just one key aspect for me. Direct payment of health care when you are sick. I can tell you this is what we need to take home. This is a problem. Now from here I can have accidents. I will not get enough money to pay my treatment. I will not be, I don't know how many will be able from you if you are not covered by someone, but it is a problem. We need to separate clearly, disconnect how I get care and how I can pay. Next, please. This, I think I said it, we need, this is a minimum, $80 per capita. But this is even general government per capita. When you reduce it will not be enough. When we bring for GDP. Next, please. Then, let us see here. When we see the economy with the indicator of gross domestic product, the developed countries, of course, when we take US, other countries, European countries, Netherlands countries, they are above $50,000 per capita per person when we divide. What they allocate for health, it is more than 4,000. US is the biggest one. Europe countries around 3,000. US more than 4,000. But when you come in developing countries, first, GDP is low because they are poor countries. Then also the allocation for health is around average 5%. It's nothing. This $34 when you need 80, it is nothing. When you ask government to pay salary better with $34, pay drugs, pay everything, it will not work. I think we are just I don't know how to say, you are just pushing government what they are not able to do when we go in data. Next, please. But this is not the staff problem, but it's a problem. I think already I said this one. Next, please. Then I think also also I will discuss it. The structure of economy is essentially informal sector. Government in developed countries, there are no mechanisms to enter in informal sector and get money. And when we get, for example, almost 20% of transaction is in kind. When you go in rural area, I just have my banana, I eat it. I don't need money to buy it. It means the structure of economy is a problem. Next, please. Next. Go ahead, go on. Why I'm bringing medical tourism for resource mobilization? Because Africa, in certain time, it is a great place to live. welcome in Africa, welcome in Rwanda. You have a good weather, you can come, you can enjoy. But if we can combine, I come for my vacation, same time I have a qualified, very qualified hospital with the best doctors, well paid, provide me a care, then I can get my time. I can have 3 days of treatment and 1 week of enjoying my vacation. This what, but problem, next please, let us go ahead, go ahead. When you take India now, in 2001, in 2012, they managed to mobilize $2 billion of US dollar from medical tourism. 2 billion. South Africa less and Tunisia, but it is a lot of money. Next, please. But for the last slide, what I can say, if you mobilize those resources, I join my core area. When you mobilize those resources, how mechanisms you have to bring the system, share it equally, and everyone can use it. This is a question I would like you as a student, you come on board, you come to think, how can mobilize with those strategies and equitably use it and get everyone enjoy it. Okay. Then, previous slide, please. This is just one point for me. Private sector. Let me tell you, my colleague, let me tell you, when we take expensive technology we are getting, government, individual people who have hospitals, they will not be able to purchase it and to maintain it. They are expensive. Then I think we can have win-win, and we are developing those programs. You can have a manufacturer of this X equipment. He brings equipment, we have market, then we share the revenue. Then population will get services, and then you get technology, you get to be innovative. We need to get on board the private sector with different strategies. Next, please. Next. Then, this is for me, it is speaking. Really see it. I don't know if I have it quickly here, but USA as a country, the out of pocket, when I go to pharmacy, in the mall you have pharmacies, you have everything. The out of pocket, direct payment from the pocket, not from insurance, not from government, it is 26 billion of US dollar a year. It is a lot of money. And this money, because people pay small, they don't see that it is a lot of money. But it is money that, this is what WHO is saying, let us see how you can have a strategic purchasing. How can we avoid direct payment, then pool those money, organize the money very well, and then use it properly, and people can get better care and affordable care. And this is, you see, I select some countries, including higher income, middle income, and low income countries. Let us go next, please. Why I did it? I did it because I did an exercise. I see that we can have a limited expensive package that is below 10% of the total health care. It means surgeries, inpatient hospitalization, all those expensive. The people who are facing those care are little. But if you have a risk sharing. If you share the risk, it means you can share by increasing a bit for low prices, or you can have some risk sharing through insurance or through Social Security. When you do it, just when you ask a US citizen to pay $1 a day, just $1 a day from excuse me to say it, for those non-healthy food, just accept $1 a day. If you ask India citizen to take $1 a week, if you take Kenya citizen to take just $1 a month, you can pay, you can pay, as you see it, you can pay those surgeries, those expensive care. You understand? Next, please. I wrote a small book about it. This is what I call $1 health insurance, because I got those data from Kenya, from Uganda, from Rwanda, and from US, and some countries. Then I did some analysis about it. Next, please. I won't save our time. Let us go to some aspect of better management, better using of money, strategy in purchasing. You know, there are some programs, some schemes. We have, me, I'm government, you are hospital, you are managing hospital, you have staff. I need to pay you. Do you know that we lose a lot of resources because not properly managing hospitals? But if me, I come and say, you know what, because I have population money, it is not my money as government, I president, I prime minister, this is not my money, it is a tax. I take it for population. Then you are providing service population. I need to link you. I need to say, what I give you, I attach some service, some performance, some results. And then we have some way to do, we have some mechanisms to do, but this is impact evaluation done in Rwanda, using, attaching money to some key results. You are saying that you can improve some services. Next, please. In terms of different services, you are seeing there, general service, the service, they continue there. You can improve with the same money how people get services, and you attach quality. You attach scorecard for quality, you attach a scorecard for efficiency. Next, please. And those scorecard is easy to develop based on your need. Next, please. I finished to say that for me, without to bring private sector, because the big part of economy, the private sector, will not move. We continue to turn around. Thank you very much.
Thank you so much. So in summary, we need public-private partnerships more than ever. $1 health insurance can actually be a reality, and we also need to be strategic in our healthcare financing and in our purchases. Last but certainly not least, I'd like to invite Pharmacist Mutembe to also give us his perspective before we wrap up with a round of questions. Thank you so much.
Thank you very much. My slides are going to be a lot, some of them will be similar to what Dr. Claude presented. I hope maybe it will go faster. So, go back, please. Yeah, private sector for sure has a key role in the economy, as I had mentioned earlier, because private sector in the pharmaceutical field produces nearly the maximum of pharmaceuticals, medicines, vaccines, including consumables, for the health sector. And this is something that we lack in Africa. There's a big gap in Africa because we have very few WHO pre-qualified facilities. Countries like Kenya in East Africa has the most numbers of pharmaceutical plants, but they have only one that is WHO pre-qualified. So it means that I hope all of you understand the WHO pre-qualification. This actually will set the tone to the rest of the slides to explain how impactful is the pharmaceutical sector to the global economy. WHO will actually give a set of norms that pharmaceuticals need to comply with, so that they are recognized, so that some big initiatives can actually purchase meds, and it's more or less like a label, because it's a label of safety, a label of quality. Unfortunately, we don't have that in some of our countries. And when we have a a big amount, a huge chunk of pharmaceuticals that we import within our regions that are not of good standards, of good quality, because of a lot of things. Of course, the cost of the products is really important to our economies. Not only that, we don't have those products available for our market. So what happens is we import them. Some countries that do a lot of production, like South Africa, like Egypt, Morocco, have sometimes 25%, less expensive than the brand names that come from the originators, who usually are from European countries, from the US, and to say the costs are really high. One thing that is also interesting is that the pharmaceutical companies have to make money. So they invest, and they always, especially the wealthy ones, are spending a lot of money in research and development. It's really important, and that's another thing that we lack in our region. So they're way ahead. Next slide, please. So just to give you an example, in 2014, you had new cancer meds, 1,900, 560 for cardiovascular diseases, 1,308, and 1,261 drugs, new drugs for infectious diseases. So when you talk to pharmaceuticals and you tell them to kind of reduce the prices to kind of fit our economies, it's really tight because it's very difficult for them, because they spend a lot of money. You've seen it. They spend a lot of money in research and development to get those pre-qualifications and to get the authorization from, to have their products marketed. So they have to have that ROI. They have to have that return in on investment. And you won't tell a manufacturer to sell under what he has invested. Next, please. So this is an overview of the pharmaceutical market. I actually brought it back. It's again in 2014. Probably we'll get more accurate recent data because some of these drugs started, let's say, that 2017 are still on the pipeline, or maybe some of them are being put on the market. But if you look at the market, you see like the Americas already is really huge in terms of production, and when you look at Europe and Asia, they follow. But look at where, for instance, the Middle East and Africa are, and here we combine this data combines the Middle East and Africa. Next, please. So this is now R&D, and surprisingly, one would think if we talked about the automobile industry, one would think that actually that's where a lot of money is spent in terms of R&D. That's not true. A lot is spent in pharmaceutical technology, in research and development. And this really shows you how much companies are spending, to develop new moieties, to develop new products. And of course, you have a big chunk in the US, in Japan, in EU, and China. Next, please. Yeah, those are numbers that show the growth, in terms of industry. This combines both R&D and the sales of the products. In billions of US dollars, it's a lot of money, and it keeps increasing, which shows that these companies are not receiving subsidies from the government. They're actually contributing to the economy. These are privately owned companies, and they just play around the rules of economy. They do JVs, joint ventures. They buy a less performing company, but they keep growing and they keep, you know, they have good numbers. When you have a major economic crisis, you will see that some of these companies have still made profit. Next, please. Yeah, the cost of pharmaceutical, I think it joins what Dr. Claude was talking about, only that you have to see, and I'm just pointing at Kenya there, that has, you know, this is procurement. You look at the taxes, because taxes are really where the government, you know, gets its fair share. And government needs to run the whole system. But when the taxes are not well paid, then there is again a gap. It creates a gap somewhere, and the system just collapses somewhere, somehow. And when you talk about the margins, you see the retail margins. For some countries, especially in high risks, you tend to import cheap products. Let's call them cheap. Let's call them inexpensive pharmaceuticals. They come in country, and what the manufacturer will do is they will inquire what costs locally the originator's brand product. And then they will try to fit in the product in between. But their level of R&D is extremely low. They have done the researches. They just used the system and the legislation. They've used the TRIPS agreements to kind of position themselves. And at some point, they make a lot of money. They have huge margins, and somewhere, somehow, some of these originators start losing in again. That's really part of what happens in the pharmaceutical sector. Next, please. Yeah, this has been mentioned earlier. You know, GDP per capita, how people spend. Depending upon their earning, healthy population becomes wealthy or wealthier. Next, please. Yeah, this is income per. Next, please. This was about the pharmacist within the pharmacy, but I'll skip this slide. Next, please. Well, that kind of joins what I was saying earlier. Next. Those are the downsides now. I mentioned a few of them. The lack of having manufacturing plants in country causes all that. You have a poor economy, first of all, because you don't produce, so you spend your foreign currencies, and it just causes the imbalances in your system. Next, please. Pharmacovigilance is a very important component of the circulation of medicines and products, in a country. An ineffective pharmacovigilance just comes and adds up to the issues that we already have. You'll have more risks linked to drug adherence. You'll have more of the treatment failure. You'll have the more presence and circulation of counterfeited products. You'll have incorrect use of medication. Next, please. I wanted to mention some recent achievements here in Rwanda. Yeah, of course, the registration is something that has been ongoing in the East African community. That is the harmonization of registration, which is really great. Now countries can actually share, can actually have joint inspections, can do joint registration, which will facilitate, investment. But of course, you also have all the facilities that have been geolocalized here. So the Ministry of Health knows where, what pharmaceutical facility or pharmaceutical establishment is exactly. And there's also this Ministry of Health platform that really helps for the registration, the importation, the exportation of pharmaceutical products. Yeah, the medical and the prescription system. Yeah, I wanted to talk about the Umuti Health website, which is something that a young pharmacist, a student pharmacist, invented, and he gives information, basic information to every Tom, Dick, and Harry, and he gives it in Kinyarwanda and soon in English and then in French. So we're talking about how information can be shared, can be given to professionals. So it's actually a very good tool. And of course, pharmaceutical production is something in the pipeline. Here, next, please. Next. I mentioned counterfeited and substandard. Please, next. Lessons learned is basically what we've been discussing here. We have to think big, thinking out of the box, think production. Of course, stay focused. People who made it, they started with one thing and they kept pressing on to one very thing. You can mention them, the Google, Facebook, Apple. The people who started slow, they started in the garage and they just pressed on. They focused on one thing. Let's not look at quick returns. Let's aim at long-term investment, and that's really what has driven big businesses and economies. Of course, promote entrepreneurship, joint ventures. I think I've said, but I'll never say it enough. For someone to be interested in a potential investor to be interested in you, you have to have started something. You have to have something handy. And then the person comes and looks at what you have and then chips in. I think even for a potential donor or a potential business angel, you have to have something handy. And you have to have started something. Of course, co-investments, it has happened a lot with other sectors. I've seen that in Rwanda, but in Kenya, I've seen they have done what they call the Doctor's Plaza, which is really a very brilliant idea of doing things. They built a building and they have different specialties, and when you go, so you can do the medical tourism that Dr. Claude was talking about, but at the same time, you get your treatment in it's just basically a one-stop health center. Next, please. Actually, that was my last slide, and I wanted to end up with one beautiful saying about East Africa, which is, it's actually a motto of East Africa, which is one people, one destiny. Thank you very much.
Thank you so much. One people, one destiny. I see some of us have burning questions, and you're in luck. It is the question and answer session. I'd like probably a microphone. Unfortunately, due to the interest of time, we shall only take 4 questions. So we'll have the first gentleman in the middle. He's been raising his hand since before we started the PowerPoint. Then I need a lady for gender equity. There is a lady at the far back, almost jumping out of her seat in black and glasses. Yes, in the middle row. Then finally, we'll have the gentleman in the gray suit on my left. And then we'll take one on social media. And last but not least, another lady there. So please, let's keep our questions as brief as possible. We are short on time and we really need to wrap up. Thank you so much. And kindly introduce yourself, first name and probably country. Thank you.
Yeah. Thank you. I'm Bidian from Kenya. Thank you. So from your discussion, one thing that has been very constant is that the government doesn't have enough. And again, that we are not doing things right. So I was wondering, health financing has been expensive for our government since the year 1990s. In 2000, it was expensive. 2010, it's expensive. 2017, it's still expensive. It's actually rising. While communication started expensive, we were buying SIM cards to almost $20, and down the line, it has become cheaper to communicate. Transportation was very expensive, and down the line it gets better. Almost everything started to be very expensive, and down the line it gets better. So what's so different with health? Is it, what are we getting wrong? is there something so important that we are missing, and so that it keeps going up instead of down? Thank you.
Second question, please.
Thank you. I'm Lily from Burundi. So I'd like to ask this question to Mr. Mtembe. Don't you think that one of the reasons why we are struggling with financing in healthcare is that we focus more about how to cure, how to heal sicknesses or diseases with medicines, more than we talk about how to prevent, how to avoid those sicknesses, because we can avoid them in a natural way, like sports, like how to eat well, and instead of doing that, we are more talking about medicines, more about financing those stuff and other. So don't you think that now healthcare is on its way becoming a pure and simple business, and that's why maybe we are struggling with financing? So thank you.
Thank you so much.
Hello, everybody. My name is Bridget, and I'm from Kenya. So I have two questions, but first of all, maybe a bit of a background. I'm sure all of you know the limelight negative that my country has been in much of this year in terms of its healthcare, from the strikes to national health insurance scheme being turned into something else, more of a profiteering session, whereby you find, let's say I'm employed, I'm covered by national insurance, I remit my monthly subscription to that. At the same time, I've decided maybe I need a better scheme. So I've picked up some other insurance policy from a private company. Let's use A or N, for example. So the scenario is back home, if I go to these high-end private hospitals, they will first of all want my NHIF, National Hospital Insurance Fund, to cater for some expenses. And then after National Health Insurance Fund has catered for them, the private will step in, which leads to a scenario whereby you find NHIF that is ideally meant to equalize everybody, cater for the extremely poor, and okay, so get the rich to actually pay for the extremely poor. So you find a scenario whereby NHIF has wound up giving a huge chunk of its money to the rich citizenry, at least people who can afford to even get a second policy, while people who are languishing in public healthcare facilities do not even get basics. Like currently, it's been scrapped to down to about 4 visits per family per year, 1 surgery per family per year. So, which leads to my question, are there measures, in as much as yes, people are meant to finance healthcare and actually get a profit out of it, like are there measures to prevent this sort of greed that is going on? Like, are there measures to prevent that from happening? And then secondly, about health financing, I'm sure most of us are aware of the Abuja Declaration of 2001, whereby some 26 states in Africa actually sat down and agreed that 15% of their revenue would actually go to financing healthcare. And right now, almost none of those countries are compliant with that. So in terms of advocacy, are there other avenues to actually push them to do that? Do we have legal options? And if at all they're there, have they been pursued? Has anybody tried, for example, suing those non-compliant governments? So yeah, those are my two questions. Thank you.
Thank you so much for the questions. Final question.
Thank you. Geoffrey from Rwanda, representing International Doctor Booking, East Africa, and same time capacity development expert. When we talk about health finance, it takes me back to my mother who would manage small money at home to avoid me to become stunted and balance my nutrition. And again, here in health financing, again, come back to where we come from. our universities, where we don't involve students in trying to budget for maybe laboratory equipment or internship. The student is there, he doesn't know how these funds are coming in. And when he finishes schools, he goes out and then he has a gap in health financing. So what I'm trying to say, the demand side and supply side, there's a mislink. So we need to see, I think, advocate for this and see how they balance. Because even up to date, if you go to Minister of Health, there's some who don't know how we're gonna fill this gap of health financing. And again, Dr. Claude brought the issue of innovation, innovation mechanism, and our colleague from Holland is talking about aid. We all know that financing is reducing. So how are we ready to see that health financing for health is reducing, donors is reducing? So what innovative mechanism are we going to use to see that we sustain health financing? And again, when you look at how much we are mobilizing, it's a lot of money. And I think in Dr. Claude's presentation, he's trying to tell us, please, let's be innovative and see how we can internally mobilize our funds, because the international financing is reducing. We have seen civil society organizations that are intervening in health financing closing because the donor financing is reducing. So how are we prepared to see that there is that sustainability? Thank you.
Thank you so much for that wonderful question. There's also one very interesting question on social media from Bella from Sierra Leone. He asks, the financing gap between cost of achieving the SDGs and the potential for low-middle income countries to mobilize domestic resources is large. How can we close this gap? And I'd like to welcome our panelists to answer all our questions, starting with Renee. I think we have quite a number of questions on advocacy, so kindly could you help our audience in answering some of their questions. Thank you so much.
Yes, thank you. On the first question, why healthcare gets more expensive, I think it's because we want the best for everyone. And every time we invent something new, healthcare can, I mean, not always, but it can get more expensive because we have access to better medicine, better diagnostics, but they come at a cost. And we believe that people should have access to it. Well, I think the question on prevention was a very good one. And I think it's all about prioritization and think where can we make the most out of our money. It's about cost effectiveness and checking for it. If we look at the Abuja Declaration and the target, I think indeed it's a pity that it's not working, but there's always a lot of challenges and reasons why did this not happen. I would love to see that there were binding agreement that every government is mandatory to provide healthcare for its citizens. But I don't see it happening anytime soon at the World Health Organization or at the UN to have binding agreements on this. So what you really need is then from bottom up to make noise that there's more needed in the healthcare system. I think the last one I'm going to answer is on the funding, the global funding, which is reducing. I believe that every country should step up if they have the capacity and provide aid to countries who need it, but they should provide it in a way that it's truly beneficial for the countries and that it matches with the needs in their healthcare system. Now, if it reduces, it's not necessarily bad because it depends what kind of money. If it's the vertical projects who are now decreasing because it's integrated into the system. And global aid could also be more effective if they pool together. If the Dutch money goes together with the Danish and the Belgian money, and that is spent on one big project, the health system. Now, civil society is always a struggle to get funding for, and we keep on proving how relevant we are, how much we're needed, how much the voices are needed, but I think this will always be a fight.
Thank you. I will select some key. I'm more comfortable. I think for me, let us really be realistic. When I see the level of some countries in terms of economy, less than $1,000 per capita, then you see the gap between a country that has $50,000 per capita. When I say capita, it is you divide by population. It is equally. The gap is huge. I think for me, thinking we ignore global aid from rich countries, poor countries, it is a dream. It is not realistic. I think we need to continue to do advocacy. I'm happy my colleague, his job is to do it because it is necessary. The reality we need to develop our economies, but meantime, we need people not to die, to have quality of care. I think we need to balance this one. This is the reality. We can mobilize, we should mobilize domestic resources, but we know that even we need to save the life of people now, not let people dying, then we solve problem. No. We need to save the life of people, and we have no means now. We need to do our best. When I come to the colleague from Kenya saying how the schemes, and I'm come to public schemes and the private insurance schemes. I think somehow for me, based on my experience, we need to separate functions. I can give you an example for Washington, D.C. state. It is not really a state district, but how they used to finance poor people using public money, then they changed the rules. Why? Because they were giving money to hospitals, give care to poor people if they come. People was misusing it. But when they said, no, let us agree. What is the cost? In efficient way, then we separate. You give care, I assess, then I pay you. If you cheat, I remove it. When you check some public scheme, I will not go to specific for Kenya, but there's some conflict of things. I'm government, then I'm regulator, and then I'm manager of a scheme. Then I will not regulate myself. I think in this, for example, in Kenya, they have Kenya Insurance Regulatory Authority. This authority should be able to go in public scheme for health insurance and regulate equally as a private scheme. Because when you see, I can tell you, so many public schemes, because of poor management, they use more than 50% of money for bureaucracy, for administration. Do you think this is not acceptable? It means I get money for people to give care, I use for my salary, my bureaucracy, my car, no, this one should be really, I'm happy you raised this issue, but it is not for Kenya, it is for many countries. Then, I think she left, the colleague, she raised the issue of prevention and curative treatment. I think let us be realistic. To treat someone who is sick is expensive. Why not to focus to prevent someone to be sick? Because you have no money. Because it is not normal that when I see, for example, people, how they're misdriving the motor, they don't think that when they fall down, the cost to be treated will be very huge. Then we need really to highlight everywhere, even for advocacy colleagues, even for advocacy, we need to raise those issues of prevention. This is the way we can be efficient and reduce the cost because we have no enough money to do it. Innovation, my colleague Geoffrey was saying, we have different ways to innovate how we are doing business. From how we mobilize the resources and where we are mobilizing and how can we use it. And I'm happy my colleague raised the issue of technology. Because with the technology, I can tell you, we didn't develop much in Rwanda telemedicine. we are coming with some products, but why not I can insist to go in India? Why not someone by technology, existing technology, can do my consultation from here with video consultation and then prescribe me some laboratory tests. I go to laboratory, get tests, I send him the test, and they say, you know what, you may have this one. Then, if it is necessary, I will travel just for I think we need to bring any innovation to reduce the cost as much as possible and to increase our efficiency. I think I will stop here. Thank you.
Thank you very much. I think my colleagues have touched to almost everything. I'll just, I think because Lily had asked the question, maybe I'll just complement to what has been said by Dr. Claude. It's true there is, for instance, for Rwanda, there's a drive to try to prevent in so many ways. It was also earlier mentioned here in this room that I think it was a delegate from India talking about how he goes to rural areas and they teach people, you know, to basic hygiene. So there is a drive, you know, through different initiatives from I'm giving example from the government of Rwanda because those are the ones that I know, through the Rwanda Biomedical Center, you know, to, for instance, curb on the NCDs, the non-communicable diseases. We see that, and that's the trend. You see that as countries get wealthier, people get sicker. They get more obese. You know, they start developing diabetes, high blood pressure. So it's you know, a lot of now teaching. Now we're not talking about teaching students, but it's a lifetime, you know, teaching. You're not talking about people from rural areas because most of the time they are not concerned. Even though from time to time they have, those, you know, those issues. They have maybe issues related with hygiene. They get disease due to poor hygiene. But people in urban area, on the other hand, are faced with even more disastrous or even more disastrous diseases. When you hear about, you know, the causes of cancer, for instance, they are so ubiquitous, you can't name all of them. And we see that cancer has increased drastically as countries developed. So you have even treatments. I think we're talking with colleagues here. We have antibiotics that are not working anymore. So the fear is, even with innovators, in the next 5, 10, 20 years, you'll have diseases that are extremely smart, that you really can't just easily treat, and you'll go back in the early, you know, early 19th centuries, where people were getting sick and they just didn't know how to treat people, and you had masses who were dying. So yeah, I totally agree with you, and I just will tag along to what Dr. Claude was saying. Prevention is, you invest probably less to gain more. And of course, the end results are really, really clear-cut. And I think I'll stop right there.
Thank you so much to our lovely panelists. I know Money Matters will always go on and on and on, but unfortunately, we're a bit held up for time. First of all, I'd like to thank our lovely panelists for being here for this session and giving us their respective views on financing in healthcare. Just to wrap up, as healthcare students and as healthcare professionals of the future, we need to be, one, advocates in financing for healthcare, because if we want change to happen in our healthcare financing systems, we need to be advocates for change and adequately say what we need to be changed. Secondly, we need to get smart and we need to be strategic in our healthcare financing. Sometimes less is more in investing in healthcare, and preventive measures probably is one of the ways to help us improve our healthcare financing. And finally, innovation. As technology improves each and every day, we should also think of innovative ways of improving our healthcare financing systems and also how to engage our various stakeholders. And last but certainly not least, public-private partnerships is very important towards financing in healthcare. Finally, before I give the announcements, I'd like to thank you all, the audience, for being with us. Please give yourselves a round of applause. And also, once again, I can't say this enough, thank you so much to our panelists. I think they need also a round of applause. And finally, to wrap up, today is Cultural Night, and it shall be held at the Hilltop Hotel from 8 p.m. So for all of us, it's a time for us to embrace our different cultures and also probably exchange notes on healthcare financing and see how we can improve on our global perspective of it. For all international delegates, the buses to the Hilltop Hotel will leave your respective hotels at 6:30 p.m. sharp. So kindly let's keep time. Dinner shall be at the Hilltop Hotel at 7 p.m. And immediately after this session, you're being requested to head to the buses immediately so as to head to your respective residences. Thank you so much for joining us in this session, and I'd like us to once again be advocates for financing in healthcare, and remember that we need to be strategic in our financing for healthcare at our various countries. Thank you so much, and enjoy your evening.